Let me share. And yeah, can you see my screen?
Yep, we've got that.
Yeah, yeah. Yeah, thank you. Thank you for having me here. And currently I'm a pulmonologist, and recently I'm back to China and now worked at the affiliate hospital of Nanjing Medical University. And so this work is we have just published now, and we answer the question um, is can asymptomatic or subclinical TB states be addressed through TPT? And this is the issue currently debated among the clinicians and public health experts now. So as we know, to achieve NTB goal, WHO set target, including 90% reduction in incidence between 2015 and 2013. And the NTB strategy promotes two pillars. The first is active case finding for early diagnosis and treatment of TB disease. And the second pillar is the preventive therapy for the treatment of TB infection. And this is based on a historically conceptualized dichotomy in the TB paradigm. And one is the active case finding for active TB disease, and then the TB prevention therapy for latent TB. And for chest X-ray, as we know, have been firstly adapted in New York City, and it has been successfully controlled the TB epidemic, and after then also among most of the developed countries. But in 1960s, because of the high cost of chest X-ray, WHO no longer recommended active case finding or mass X-ray among the developing countries. And the WHO only recommended screening for symptomatic people. We call it passive case finding. And since 2015, WHO NTP program and recommended X-ray screening combined with symptomatic screening for high-risk population. But WHO only recommend X-ray screening limited to people aged over 50 years. So we can see that X-ray screening have been facing a lot of barriers now. And one is for young children, WHO not recommend X-ray screening, actually, due to the potential false positive for CXR. And also there is a limited availability of X-ray. And for the shortage of trained radiologists, and this for human resource limitations. And also there is a variability in interpretation because clinicians often don't trust X-ray findings because of their low sensitivity and specificity. But because X-ray screening have been adopted within the past century, so now we have historical cohort data. And there's two interesting findings. First is 30 to 50% of sputum culture positive patients can have the prior abnormal X-ray. And the second is individual with abnormal X-ray but negative sputum can have 1 to 10% annual risk of developing culture positive TB. So because of these findings, we ask questions. Among the high-risk population, could X-ray abnormalities indicate the early or subclinical TB? Our previous findings and in the Peruvian cohort data that we found the baseline abnormal X-ray finding may indicate early subclinical TB and can indicate the trajectory of TB disease progression within following 1 year among household contacts. And this is also we observed a similar trend in children and adults. And also we have another interesting findings in this cohort is that we found that even for children who less than 15 years and with abnormal X-ray baseline, the IPT intervention among this group can still reduce TB incidence by over 80%. So it's interesting findings and also provided us a window for earlier diagnosis and treatment for TB. So now we can know that between latent TB infection states and active TB disease, there is a dynamic of TB disease spectrum. And we call it like subclinical TB, incipient TB, or early TB states. And all these different terms means actually the same stage. And also in 2024, there's an international consensus for early TB stage framework, just in provide just showing the importance of this stage. So WHO 2024 global report has just indicated this asymptomatic TB as unified terms for all of these terms for this stage. But currently, no standard management guidelines for early TB stages from WHO. So we just I just draw this diagram that we see for people who expose to TB and they might then have TB infection and then can progress to early TB states. And from early TB states may progress to TB disease. So we ask, what could be happen if we provide intervention both for TB infection and for early TB states? And we hypothesize this could provide the optimal outcomes after these two interventions. But we also hypothesize that either for the intervention for TB infection and early TB states can incur the harms, which may means that a severe activities SAE, that means side effects, and also the benefits means the incidence reduced. So for clinicians, it also facing a lot of challenges. First, there are uncertainties in decision making because the lack of evidence. And also there is bioethics issues that weigh the harm from treatment and benefit from disease prevention. So if they treat for TB infection, may have the risk of inadequate treatment for TB disease. If the treatment for TB disease, like there may be the risk of overtreatment for non-disease infection. Also, even for old adults may have a lower tolerance for TB drug toxicity. So, but there is urgent to make this decision because most infected household contacts develop disease within 1 year. Our study aimed to evaluate strategies for managing household contacts with abnormal chest X-ray, but who don't meet clinical criteria for TB disease. And second is to help fill the knowledge gap and better leveraging accessible tools in high-burden, source-limited settings. And third is to establish the model comparing benefit and harm of different community-based care management strategies to support policymaker. So our model built on combining the real-world cohort and the hypothetical cohort. Our real cohort set up in Peru between 2009 and 2012, and we enrolled 4,500 index cases and over 14,000 household contacts. And we follow them up for over 1 year. And the household contacts of patients with newly diagnosed with drug of patients newly diagnosed with drug-susceptible TB and who were eligible for TB infection treatment. And also, they have been excluded TB disease at baseline. And we extracted parameters of this real Peruvian cohort. And in this cohort, there is a different TB X-ray abnormalities, a TB abnormal population proportions among different age groups. And also, for Peru's national TB program, only the children and the young adults less than 90 years old could be provided the TPT. So also there is another challenges, as I have mentioned earlier, that for chest X-ray, they have limitation in sensitivity and specificity for TB detection. And I just show 3 cases here because we can see even we have similar findings in X-ray, but there might have different judgment by the radiologist. And the first 2 cases, actually they have no TB disease. And the last case, the third case, that he developed TB disease subsequently. So we can see that real early subclinical TB disease can be the third one, But for the first two, they could be undiagnosed TB disease or latent TB infection with non-TB disease or abnormalities. So it's a very so it's a complex issues for X-ray reading. And actually, in source limited settings, there is also could be more accurate screening tools such as CT, PET-CT scan, but they're often unaffordable and inaccessible. So why are we break down this X-ray abnormal household contacts? We can see there is we can divide them for two groups. The first group is non-TB lung abnormalities, non-TB lung abnormal population. And the second is the real early TB disease population. It means this population can develop subsequent TB disease. However, we actually don't know how to select this real early TB disease. But if we given this population a TB treatment, we know for the red population can be will have the effect of the treatment, but for the non-disease latent TB infection population may have only the side effects. So intervention for early TB disease within uncertain diagnosis in the low middle income countries may create both benefit and risks. So it's our basis. And now we want to modeling this population eligible for TB infection treatment, which means they have been excluded TB disease at baseline, but they still need the TPT. And we stratify them by the X-ray results. And we can see the first one as X-ray normal population, and the second one X-ray abnormal population. And for X-ray abnormal normal population, we give them two choice. One is non-treatment, that means the control arm, and the second is prevention therapy. And for X-ray abnormal population, we give them three choice. First is the control arm, no treatment, and then prevention therapy and treatment for TB disease. And all of different treatment could have the TB disease and SAE outcomes. And we also modeling down on the different age groups, including 0 to 14 years old, 15 to 35 years old, 35 to 64 years old, and over 65 years old. We also modeling on X-ray screening results for normal X-ray and abnormal X-ray. We also modeling on the treatment options. First, the treatment of infection, and including the WHO recommended regimen and 6-isoniazid, 6H, 3HP, 4R, and also treatment for disease, like the first line drug regimen. And we set the modeling outputs for for incident TB disease, severe adverse events, and acquired drug resistance. And here we assumed severe adverse events with grade 3 to 5 events leading to treatment discontinuation, hospitalization. And so we assume that SAEs leading to treatment discontinuation could increase the risk of the disease progression. So we assume people who develop SAE would not benefit from treatment. Here is our decision tree framework. Just I showed earlier that we did stratify them first for X-ray abnormal and normal results, and then we gave them different treatment options. And first, we established hypothetical cohorts and stratify by age group, and just 4 age group I showed earlier, and the population, the number of cases for 1,000, and we set up the 3 different strategies. The strategy 1 is universal TPT, and that means that we provide the X-ray normal population and X-ray abnormal population, both of the prevention therapy. And the strategy 2 is X-ray guided treatment. It means we provide X-ray abnormal population for their active disease treatment, like first-line drugs, and for X-ray normal population for TPT. And the strategy 3 is the control arm, means observation without pharmaceutical intervention. And the second, we further modeling intervention of the two strategies among three different situations with different age covering. First, we're using two strategies covering the ages of household contacts only less than 19 years old. And second, we're covering the age less than 35 years old. And second, we're covering all of the age groups. It means scaling up to older adults. So after then, last one, and we modeling the two intervention strategies by different uptake rate. And because in the pre-cohort data, the real uptake rate is around 50%. So here we are modeling the 25, 50, 75, 100% of uptake rate. And we also modeling the two intervention strategies by different TBT regimen. And we use the three different regimens which have recommended by WHO for TB infection. The first is 6 months daily isoniazid, and 4 months daily rifampicin, and 3 weekly isoniazid and rifampicin. And we also combine these three strategies. So for the treatment regimens for TB infection, we first using modeling the IPT, because currently WHO endorsement for 6 months IPT, and IPT has been widely implemented in low-middle income countries. So we have a lot of evidence, and actually we have the efficacy of IPT treatment for the X-ray abnormal population around a historical cohort. And we extract data from a systemic review and for the other different TPT regimens for the intervention. But however, we still don't have the evidence, have enough RCT data for the TPT regimen for abnormal X-ray population. And so we assumed that like the 3HP, 4R, and have the similar efficacy for the early TB states for X-ray abnormal population and as the IPT. And we using their SA risk data from this meta-analysis. And for treatment regimens for early TB disease, we currently using the WHO recommended regimens for DSTB, and it means standard first-line TB drugs and HRZE. And also, WHO has recently recommended that for children for non-severe TB, they can use a shorter regimens. So we also use a 4-month shorter regimen for children in our cohort. And then we also extracted this different data of the TBT regimens from published RCT. And here is our model equations. We set up this terminology to represent each parameter. And first, we're modeling this non-pharmaceutical intervention scenarios as baseline. And then we're modeling this universal TPT scenario. And then we're modeling the X-ray based treatment scenario. Further, we're modeling these 6 management strategy scenarios. And this means first we modeling the non-treatment scenario for all population, and then we apply that the universal TPT or X-ray guided regimens for the 3 different age covering situations. And further, we modeling the scenarios with different uptake rate. And for the point estimate and uncertainty calculation, we use the moment margin for point estimate, and for uncertainty in probability risk parameters, we apply the beta distribution. And for the uncertainty in the risk ratio parameters, we use a log normal distribution. And we use Monte Carlo simulation for sampling from the joint distribution and produce estimate of uncertainties. And also this originally from the published paper in our colleague. So the main findings, first, the output is we output the data and stratified by X-ray screening results. And we can see there's two rows, and the first row is for X-ray normal contacts, and second row is for X-ray abnormal contacts. And the X bar shows the SAE per 1,000 contacts, and the Y bar shows the risk of TB disease progression per 1,000 contacts. And we can see among the X-ray normal contacts, both the SAE and the TB incidence risks was very high. Oh, sorry. Wait a minute. Sorry, for breakdown. And we can see for the second rows, um, among the older population, their TB incidence risk was decreased, while their SAE risks was increased. So there's a different, it's the most difference between the two groups. And for second outputs, we just modeling the two strategies among different age groups. And the TB case reduction and SAE incurrence among different age groups would be compared. And we see just see as the age people get older, and the TB case reduction could also be decreased, while in among the older population, their SAE case incurrence also increased. And for TB IPT, for all means universal IPTs, universal IPT strategies could have less efficacy than the X-ray guided treatment, while the SAE risks in cases incurred by universal IPT could also would be also lower than for those with X-ray guided treatment. And this is output for the drug resistance. It's isoniazid resistance acquisition with different strategies. And this I think because currently this still the issue, and we don't have very strong evidence from the published data. So I think because the case risk is still very low, so I just show here. But I don't think it would be make a lot of like the difference could be discussion. So for this uptake rate, different uptake rate, we show here is the difference between the two strategies. And we see why when the uptake rate was increased, the differences within the two treatment strategies would also became larger. And we also modeling the different TPT regimens for different age group. Also, because our assumable they have a similar efficacy for the subclinical TB, so we can see the changes in number of TB cases were similar among the different TPT regimen. But we can see for the 4 months daily rifampicin could have the lowest SAE risks for in the household context, but 3 months of weekly ionized and rifampicin could have the highest risk, SAE risks for this population. So from this outputs that we consider that maybe 4 months daily rifampicin could be the potential options for the treatments of early TB states. And here we can overview the total like the efficacies for the 7 strategies, and also the first and for the 7 strategies. Oh, especially for the 6 different strategy and for the different situation. Okay, let's now see these final outcomes. And this is benefits and benefits and the risk outcomes. I combined here in this diagram. And first, we see in the two strategies in the covering all situation, the X-ray guided treatment can have the higher efficacy than universal IPT. And the X-ray based treatment also can have the incurred higher SA risks than universal IPT. And if we implemented strategies covering the household context only less than 35 years old, means young adults and children, and for also the X-ray based treatment can have the higher efficacy than universal IPT, but the X-ray based treatment can also incur the higher risk of SAEs than universal IPT. And when we using the two strategies, covering the household context less than 19 years old only, and also this is reflects the Peru's now national policy. We can see both strategy can have the lower TB case reduction, and also the universal IPT can have the less case reduction, but the two strategies also have the lowest risk of SAEs than the other situation. So we also compared the three different TBT regimens among the different treatment situation. We also find that for 4 months daily rifampicin strategy can have the lowest SA risks for household contacts. And this means in this comparing situation, we implemented the TBTs and combined the regimen in all of the population, all age groups. So we can see maybe 4R regimen combined with a first-line treatment can maybe a choice for the household context management. So let's have some conclusions. The purpose of this model was not to make treatment recommendations for high-burden settings. We illustrated how integrating X-ray screening indicated early TB states for systemic intervention strategy can lead to different outcomes for benefit and harms, and how the same treatment strategy can lead to different consequences when applied to the population in different age groups. In high-burden settings, systemic treatment across all age groups reduces the most incident TB cases in the population at risk. And the risk of adverse events can be minimized by using TBT strategies to treat young population less than 19 years old only. The results of the study might help decide when to incorporate X-ray screening results into contact management algorithms. And the cost-effectiveness study in future could help validate and refine these results to make policy decisions based on their local epidemiological situation. We still have some limitations for this model. First, the effectiveness of TPT may have been underestimated due to contextual factors specified to our setting. Our assumption about TPT efficacy may also overlook population-level effects of widespread implementation in the stable communities, which sustained uptake could reduce transmission. Second, we modeled a hypothetical cohort based on data from Peru, which may limit generalized to setting with different epidemiological profile. Third, our model applied a unified screening strategy across all age groups, despite knowing limitations of TST and X-ray in young children. And finally, the model doesn't account for broader benefit of early TB treatment, such as reduced transmission, prevention of post-TB lung disease, or stigma reduction. So I would thank our group both in Boston and Peru, and also thank my mentor, Professor Megan Murray, and this our global health group. and with the PIH partnership in health. And also I thank Dr. Profarmer, who has made these fundings from NIH. And thank you all. So I would like to take some questions here.
Brilliant. Thank you so much. That was really, really interesting to see. I think there's not that many people, so if you want to ask a question, please do ask or raise a hand. Maybe while I will give people the opportunity to think of one, though, the one that I was most struck by was, I think, what you mentioned about costs. And obviously, that's a really helpful way to then be able to make some decisions around this. But I wondered if you could do something, with the results that you already have, to compare something like the adverse events that you incur for every TB disease the case of TB disease that you prevent, something like that. Because I was just interested, I think it was in fact this particular slide I was looking at, wondering if there was a way of telling, the results are kind of what I expected, that, when you're doing under 19s only, you have fewer adverse events and less TB disease preventer. But I wondered if there was a way of sort of looking at the trade-off between the two, basically as a cost effectiveness analysis would do with dollars, but you don't have dollars, you do have adverse events. So maybe you could compare number of
Yeah,
adverse events incurred per disease case prevented, something like that.
yeah, thank you, Fan. Yes, that's a good question. Actually, we have planned to doing this estimation, but we found it's very challenging to find the evidence from the RCTs which can show like people who have benefit from treatment could develop the SAEs. The data was unavailable in most like the RCTs, so we don't have the parameters now. Yeah. So also this some limitations. So we just assumed here that people who develop SAEs wouldn't like to develop would not be reduced the TB incidence risk because people who have we assume people here who have developed SAEs SAE would discontinue their treatment. So this is only the evidence we can get.
Okay, thank you. Yeah, I'll have to think about that. Thanks. Pete, do you want to ask your question?
Uh, yeah, it's somewhat of a I'm not fully with it today. Just looking for kind of re summary, to be honest. So the kind of the new things that you're considering here. So you've got the different regimens, um, uh, but the new things here are thinking about early stage TB, and introducing X-ray, chest X-rays. And it was just conceptually, I think I missed it at the start, the relationship between those things. So what is the chest X-ray uh, doing for you in this strategy?
Oh yeah, thank you, Pete. It's a good question, but also maybe I'm sorry I didn't make it clear for the abnormal X-ray. Like I show you here the earlier slide here. Sorry. Here, yes. I would share actually here for as you know for the in clinical settings, an abnormal X-ray may indicate many different disease, can make different diagnosis. And actually, among the household contacts, because those population have very high risk of TB disease, and also these who may have early TB disease should have abnormal X-ray, but abnormal X-ray could not fully indicate a TB disease. They could also have may indicate the other lung disease, but not TB. So we can only because in Peru or in most communities of low income countries, we can only use chest X-ray to make a screening or diagnosis. Although we know the X-ray is not accurate. So we also because we know this actual situation, so I make their X-ray abnormal population. Here we stratify it with two groups. One is a real early TB disease group, but although we can't use X-ray to show that early TB disease, but for clinicians, we know there is a real early TB disease group. Other group is also X-ray is abnormal, but they are not have real early TB disease. They might just only have like a COPD, lung cancer, but they have a normal X-ray, but they are not TB. But from using X-ray, we can't indicate the accurate population. So
I,
here we use
I
X-ray just the indication for treatment option.
I see. So the role is to kind of split out, albeit imperfectly, the early
Yes,
TB disease from the TB infection group for
yes,
clinical management.
yes,
Um,
yes,
and yeah, okay, interesting.
yeah.
Eh, Can I ask one question, Phil? Yeah,
Yeah,
then,
Sandeep, sorry. And then Arne, after that,
yeah,
sorry,
yeah.
I've seen your question in the chat.
Okay, just one question on this means, if I understand correctly, uh, did you consider the adherence of treatment? Because sometimes you are considering the 6 months treatment resume or 4 months treatment resume, different resume you are considering. So for 6 months treatment resume, maybe the adherence of taking the treatment would be less than 3 months or 4 months, right? So is it been considered here in this model? Means for your this estimation,
Sorry. Yeah,
adherence of treatment?
yes, thank you, Sandeep. Maybe I'm not sure if I get your question. Do you means like I'm modeling this regimen for TB disease
Mhm.
treatment for 4 months, 6 months? Is your
Now,
question?
my question is, yeah, my question is, you are considering 6 months. Someone is getting six
Yes.
months treatment regimen.
Yes.
But
Yeah.
in your estimation, means there is
Yeah.
loss to follow up, means continuation of treatment. Taking the 6 month treatment is lesser, means what should I
Yeah. Yeah.
say?
Yeah.
Means,
I got your
yeah.
question. Actually,
Mhm.
we here using 6 months treatment for we using 6 months treatment for adults over 15 years here because
Six.
it's WHO recommended. And we use the 4 months regimen for the house contact less than 15 years because also
Mhm.
currently this is recommended by WHO. We assume that
Mhm.
the child house contacts with early TB states is similar to those with non-severe TB.
No, my question is for those who are taking 6 months resume, treatment resume, they are continuing, they are taking treatment from day 1 to 6 months, or it is happening that sometimes people start taking treatment, but they couldn't complete the 6 months duration. Maybe in the middle of them, they drop the treatment, taking treatment of TPT, especially for TPT, that happens. So did you consider that? That is my question, because you are considering the adherence effect of different treatment regimen, right? So that could be one important factor. Means whether you consider, I don't understand really. Means whether it is being considered or not. So yeah, that's my question. If I am clear,
Mm. Yeah,
means
sorry. Yeah, but I'm not sure if I got a question. So yes, and actually here in our cohort, we for the hypothetical cohorts, we giving them all the
mhm.
regimens, and we assume that they didn't stop the regimen.
Okay. That's okay. That was my question. Yeah.
Yeah.
Thank you.
Mm,
Thank you.
Thanks, Sandeep.
yeah.
Arne, do you want to ask your question?
Sure. Hi. So my question is regarding the adverse events if someone starts TB treatment. Did you include that in your model? Because you compared the adverse events due to TPT versus the benefit of preventing TB. But if you prevent TB disease, you also prevent the adverse events associated with the treatment for the TB disease.
Yeah, that's interesting questions. Let's show our model. I think we assumed prevent TB disease here. We just here, yeah. I think do you means like if I prevent TB disease as it, yeah,
If
I
you
think
prevent TB disease,
mm,
then you're also preventing the adverse events due to the TB treatment, right? Because TB disease itself, you also have to take full treatment, and patients, they're not only sick, but they also develop adverse events because of the treatment.
yeah, we didn't consider this. We
Because
just mm,
yeah, that is something that policymakers often ignore. They say, no, we're not going to give TPT
yeah.
because 1 out of 1,000 people will get severe hepatitis.
Mm,
But you have to look at the people that then get TB. They will also get hepatitis at a higher rate because they
yes.
are sick and they get more intensive treatment. So
Yeah.
it's not a true comparison of adverse events averted.
Yeah, that's an interesting point. We didn't consider it when we built this model. Yeah, thank you.
Thanks.
We considered it and yeah.
Catherine, I've seen a question from you, I think, in the chat.
Hi, yes, thanks. Really interesting presentation. I really enjoyed it. And this early TB state is something that I'm really interested in. And I was just curious how you parameterize the risk of progression from early disease to what you call TB disease. I'm guessing that's bacteriological disease. Was that informed by the cohort you mentioned? And how did that risk of progression differ for children and adults?
Oh yeah, it's an interesting question. So, for your first question is, you means the risk of TB disease. You means parameters of risk of TB disease in our cohort.
Yes, I say here on the slide that you're showing, you've got individuals who are TST positive and chest X-ray positive, say those who don't have a pharmaceutical intervention.
Yes. Yeah,
How
it's
did you determine how many of those would develop TB disease? Sorry
yeah,
if I missed
actually
it.
yeah, actually we built our model based on our real Peruvian cohort we established 10 years ago. So we have these parameters at baseline and for from this cohort. So here in this we have published this cohort actually in the past 2 years ago, and we know from this cohort, um, we have a data for the TB incidence after among the 1 year follow-up and within both X-ray normal household contacts and X-ray abnormal contacts. And they're both for there's this cohort including child and adults.
Oh,
So
fantastic. Okay, sorry, I missed it on this slide. I'll have to go
that's
look up
okay.
that paper. I was just interested in how that progression rate differs or that risk differs for children and adults in the cohort.
Yeah, this yeah. There's some difference, and I think I can show there was earlier slide. Uh, uh, yeah, this is slide. Yeah, it's and this paper is in for child house contacts, and the lower paper is show the adult study, and the right side we show the data in the adult cohorts, and we can see there's a different, very very like outstand and differences in TB abnormal population and for their incidence risk.
Great, thank you, and thanks.
Okay, thank you.
I was just trying to check, Pete, was your second question in the chat answered? I think. Was that
The second question, I don't think so, but I may have missed it. Oh no, hang on. No, that's on this. Sorry, I was distracted with something else. So that's on this slide actually. Yeah. I think it's that survival curve, in fact, isn't it? Yeah. So I think both of my questions are answered. Thanks.
brilliant? Thank you.
Thank you.
In that case, any last questions then? If not, thank you so much again. I think that was a really interesting and thoughtful analysis. It was really nice to see, and I'll definitely be going away to look at the paper and share that with others. So thank you very much again. And thank you everyone for joining us. I think we do have somebody lined up for October, hopefully, but we'll confirm that and send out an email in the next couple of coming weeks, hopefully. Thanks so much again, everyone.
Thank you, Finn. Thank you all.
Thank you very
Looking
much.
Looking forward for further collaboration with you.
Brilliant.
Thank you.